voice is looking different now. Okay, go ahead.
Sir, I did not get much of points for this, sir.
Okay.
I'll
Anyway,
just present what I.
yeah, whatever you able to get hold of, you just tell me. Let me
Yes, sir.
see how I
The
can help.
minimum, yes, sir. The minimum local analgesic concentration, that is the MLAC model, was first described in 1995. The idea was to develop a clinical model for local anesthetic drugs similar to that which was routine use for inhalation anesthetics, that is the minimum alveolar concentration MAC.
Okay, very good.
Before this much of the clinical research into local anesthetic drugs involved just comparison of fixed dose or combination with adjuvants. So that is why we have started using MLAC. And in this MLAC model, epidural anesthesia in labor presented a most clinical area to develop this approach. Since it was first described, the MLAC model has been adapted to a various of clinical scenarios, and it is used in regional anesthesia research, and it is still under research. So the main definition is the minimal local analgesic concentration of a local anesthetic is the effective concentration in 50% of the subjects or the median effective concentration. This uses up and down sequential allocation to identify the median effective concentration, that is the EC50 or dose ED50 of the local anesthetic. It is an experimental design in which the dose received by a subject is determined by the response of the previous subject. For the model to apply, the response is being measured as all or none in nature, that is yes or no, or effective or ineffective. If a response to a given dose level is above the threshold, that is, if it is effective, there is a stepwise reduction in the dose given to the next subject. Same way, if it is a below threshold response, that is an ineffective outcome, then they increase the dose to the next patient. Using this approach, texting is eventually centered around the median threshold, EC50 or ED50 for the response, above which 50% respond and below 50% will not respond. So the MLAC model, moving on, the typical clinical scenario in which the model has been applied is in the parturient receiving epidural analgesia in the first stage of labor. In MLAC up and down studies, the outcome of interest is effective analgesia, typically defined as a visual analog pain score of 10 millimeter or less on a 100 millimeter scale within 30 minutes of administration of the local anesthetic. The variable being altered in an up and down manner is the concentration of the local anesthetic administered. The first patient in the series will receive a predetermined concentration and a volume of local anesthetic. An effective outcome results in reduction in the concentration of the local anesthetic given to the next subject, but the volume will remain the same. An ineffective outcome leads to increase in the concentration by the same predefined interval. This process continues until the concentration administered is concentrated around the EC50 or MLAC. So now moving on to potency. Pharmacological potency is defined as a measure of the dilution in which the drug is effective and is characterized by the inverse molar EC50. From this, it follows that it should be useful for comparing relative potencies and for estimating the local anesthetic sparing effects of various adjuvants such as opioids. That's all.
Very good. Same article only I also referred to, but more than that, uh, when you think of why you have to know why you should use the minimum local anesthetic concentration, just like as you rightly said in the
To
very
avoid
opening
side
statement, it
effects.
is a method of comparing inhalation anesthetic agents by measuring their MAC to assess their potency and comparing their potency. The local anesthetic concentrations, if you are able to use the lowest concentration and achieve your endpoint, it saves the patient from the major complication of local anesthetic systemic toxicity. It avoids LAST. Earlier, when we were all postgraduates during our days, they taught us the concentration of local anesthetic you have to use depends on the size and thickness of the nerve fiber. So smaller the nerve fiber, lower the concentration, thicker the nerve fiber, higher the concentration. So we were taught that unless you give 2% xylocaine, it was the only drug, the highest concentration we had in those days. 4% and 5% were more for surface application. So we had 2% xylocaine as the drug before bupivacaine era, and we were taught to give 15 to 20 ml of that for a sciatic nerve block or a femoral nerve block. And we were told that if you use lesser concentration than this, the block won't be effective and patient will not have adequate analgesia. But nowadays, what we are doing, we are using a concentration as low as 0.25 or 0.125 even for a on arrival block of femoral or sciatic nerve for achieving just adequate sensory analgesia without motor blockade. Okay, so the concept has slowly changed that even the thicker nerve fibers can be blocked, but not in toto, like a complete both sensory and motor in a mixed nerve. We can selectively block the sensory alone to achieve the analgesic component without motor blockade. And that is where we started long back talking about walking epidurals, where you use a very low concentration and produce only sensory analgesia and allow the mother to ambulate, of course, with a attender in following the patient. Uh, in case there is a motor blockade and instability in the mother, but the concept of labor, walking labor epidural was achieved by using lower concentration of your bupivacaine. Okay. So this is the main reason why, so the two reasons why we want to talk about MLAC. One is by using lower concentration, we are able to avoid local anesthetic systemic toxicity, number one. Number two, we are able to selectively block the sensory alone without motor blockade in situations, especially for, I was in plastic surgery where hand surgeries were done. So if you selectively block the sensory component alone and spare the motor, when they do a tendon repair for the fingers or wrist, they can ask the patient to move the fingers and see whether the repair is adequate, whether the nerves, the tendon has been sutured properly, and whether there is any gap, or the right tendon has been joined with the correct tendon on the other side. Many times in the palm, when they repair the tendon, sometimes they mix up and make a wrong connection and it won't work. So all that can be checked by doing a selective sensory blockade. And today I learned a new word called Valant, WALANT. Any idea what is that? WALANT, Valant. Anyone who has come across that new terminology, especially when you talk about tendon repair? Vidya, Ammu,
Wide awake local anesthesia.
Wow. Somebody Googled and found out quickly. Very good.
Yes.
So it is without anesthesia, local anesthetic, no tourniquet. So earlier it was tourniquet with sedation, which was used for the repair of tendons. But now they want to assess the repair success on the table. So they do what is called without anesthesia, local anesthetic, no tourniquet, which is called Valant, WALANT, which is now very popular among the hand surgeons. Okay, so this is the reason why we have to go for this minimum local anesthetic concentration. So I have the same points what Anjali mentioned. Anyway, just if you see it visually, I think you will be having a better idea. So I'll just go for this presentation, which contains mostly the same points which he has mentioned. So the minimum concentration is the local anesthetic, which is effective, just like MAC when you say 50% of the patients don't move when they inhale the local anesthetic for the noxious stimuli. The same thing is the description given for which is effective in 50% of the subjects. And to find out this, they use this method of what is called up and down sequential allocation. So a comparison of relative potencies using the Mlac model is possible. So what you do is before assessing the potency, you can conclude the benefits in terms of reduced motor blockade and toxicity. That is the main point that you have to remember. So wherever you want only sensory blockade and avoiding local anesthetic systemic toxicity is the main reason for bringing out a concept called MLAC or MLAC. And epidural analgesia and labor was the most important uh, concept or advancement which brought out this particular, because pregnant patients are more susceptible when you give high concentration in the epidural stage. They have more vascularity and the absorption is much more faster, and they may go in for local anesthetic toxicity or inadvertent intravascular injection in the epidural space. Venous in the veins are engorged there. That also can lead to LAST. So that is the reason why if you are able to inject a very low concentration, you can avoid all these complications. So the first up and down model is you give a particular concentration and see the effect. If it is good, if it is effective, you try to reduce the concentration and try again. So go on reducing until a stage where you don't get any effect or the block is not effective. You stop at that stage and say that is the effective concentration. This is called the up and down model. And uh, so this will be only an all or none phenomena, and where you alter the concentration but keep the volume constant. So only one thing can be variable in such studies. That is, you have to go on varying the concentration, but the volume has to be constant. You can't reduce both and claim that it will be effective or ineffective. And below a threshold response, you cannot achieve a successful block. So using this approach, testing is eventually centered around the median threshold. That is effective concentration or effective dose 50%, and subjects will be above or below. Then there is another model called minimum local anesthetic concentration model. The first one was the up and down model. This is the local anesthetic concentration model. So the first patient in the series receives a predetermined volume, concentration and volume. Then the effective outcome results in reduction in the concentration given and the volume remains the same. This process continues until the concentration administered is concentrated around E60 or MLAC. Now, the potency of the local anesthetics vary from drug to drug. So, the measure of dilution in which the drug is effective is characterized by the inverse molar EC50 of the drug, that is effective concentration. For this, from this it follows that MLAC studies should be useful for comparing relative potency, just like your MAC for inhalation agent, and for estimating local anesthetic sparing effects of various adjuvants such as opioid. So if you add a opioid, for example, in pregnancy, when we want to give postoperative pain relief, along with bupivacaine, we give fentanyl also. So when you give fentanyl, you can safely reduce the concentration and volume of the bupivacaine that you give, so that even for cesarean you can give just 1.5 ml of 0.5% heavy bupivacaine with half degree of 25 fentanyl microgram. Both will make up a volume of 2 cc, and that is as good as giving straight away 2%, 2 ml of 0.5% heavy bupivacaine, which is likely to cause more hypotension than this combination. So the sparing effect is also there. That also can be studied in this. And epidural co-analgesics also have been added, as I said earlier, with fentanyl or sufentanil. And the analgesic requirement in labor was the main concept by which this concept of local anesthetic concentration reduction came because of that. So MLAC for epidural bupivacaine significantly increases as labor progresses, indicating that analgesic requirements are variable. Early in the stage when lesser diameter fibers are affected, you are able to manage with the low concentration. But when larger diameter fibers like A delta fibers are recruited during labor, when the head descends, it may require a higher concentration. So MLAC for epidural bupivacaine can be reduced by a factor of 1.68% in obese participants, which was seen in one study. And potential explanations are the reduced volume of epidural space with raised intra-abdominal pressure, increasing scapula spread, increased epidural adipose tissue, increasing local anesthetic, local tissue absorption. So all these reasons are the reason why obese patient you can give a lesser concentration and lesser volume compared to a normally built participant. So this may partially explain the increased rate of intervention in obese participants as larger doses are likely to anesthetic maybe at more than required doses we land up. We give more than what is required. So this study has proved that we have to give lesser doses and not the normal dose as we give for other patients. And these two drugs, ropivacaine and levobupivacaine, have been found out to be the most safe drug. And motor blockade can be avoided by giving a smaller concentration or lower concentration. And it is possible to quantify the sensory motor separations also. By adjusting the concentration, we are able to separate the sensory block from motor block. And the recent applications here, the up and down sequential allocation model used the MLAC model has been extended and adapted to other applications of regional anesthesia such as plexus or nerve block in ophthalmic surgery and in ophthalmic surgery. And examples include the effect of adding hyaluronidase to subtenon block assessed during minimum local anesthetic volumes to produce akinesia for cataract surgery, and the estimation of differential MLAC volume for femoral and sciatic nerve blocks after knee arthroplasty. So these are all the recent things by which we were able to do that. If that question is